we are going to talk about acute osteomyelitis, which is infection or inflammation of bone marrow, which can involve the cortical bone and surrounding periosteal tissue. And if this infection is not resolved, it will result in formation of dead bone, and that dead bone is called sequestrum, and the periosteum surrounding that piece of dead bone or sequestrum will cause formation of new bone, and that new bone is called involucrum. For example, if this bone is infected and it results in formation of sequestrum. For example, this is sequestrum. Periosteum surrounding this sequestrum will cause formation of new bone, and that new bone will be called involucrum. Now coming to etiology. In children, mostly this infection is caused by blood-borne infection of Staph aureus. For example, if a child presents with Staph aureus pneumonia and after few days he develops acute pain of one of the limbs and he refuses to walk on that limb, then it may be the clue to suspect acute osteomyelitis caused by Staph aureus. In adults, mostly it is most common site is the lumbar vertebrae. In children, most common site is long bones of lower limb. Then this infection can be implant related. For example, Coagulase negative staph epidermidis can cause implant related osteomyelitis. Immunosuppression, for example TB and cancer, diabetes, cancer treatment, vascular insufficiency and cardiovascular diseases are risk factors for acute osteomyelitis. Coming to microbiology, we've got gram-positive organisms, which include staph species, strep and propionibacteria. Staph species include Staph aureus and epidermidis, and these are most common organisms if the infection is monobacterial. And then of course MRSA, and then strep species include Strep pyogenes, Strep pneumoniae and Strep agalacti. Coming to gram negative, E. coli, Klebsiella, Salmonella. Salmonella will cause acute osteomyelitis in patients with sickle cell anemia. And then Pseudomonas. Pseudomonas is the most common cause of acute osteomyelitis in diabetic foot. That's why in diabetic foot we often do X-ray to exclude the bone involvement. Then anaerobes Mycobacterium tuberculosis. TB most commonly causes the chronic osteomyelitis, but it can be a cause of acute osteomyelitis. Then fungal infections and contiguous spread. Contiguous spread means the spread from a closed area. If the spread is contiguous, then it means the infection is mixed, and mixed infection means any organisms from these species or these species. Contiguous spread is most commonly from skin, for example Staph epidermidis, or from GI, for example Salmonella. Now we will talk about pathology. And in osteomyelitis, when there is inflammation of bone marrow, it will result in vascular dilation, and then vascular dilation or vascular congestion will cause increase in intraosseous pressure, and that increase in intraosseous pressure will cause obstruction to blood flow, and when the blood flow will get obstructed, it will cause stasis of blood, resulting in formation of intravascular thrombosis. And the second stage is suppuration. Suppuration means the infection will involve cortical bone, Haversian system, and through Haversian system it will cause subperiosteal abscess formation in 2 to 3 days. And after suppuration, then this stage comes, which is called sequestrum. Sequestrum, as I have mentioned earlier, is the formation of dead bone, and that dead bone is separated from the surrounding tissue by necrosis, and periosteal layer surrounding that sequestrum will cause a new bone formation, and that new bone is called involucrum. After sequestrum or involucrum, Last stage is resolution. In resolution, this infection will get completely resolved by antibiotics, or it can result into formation of complications, for example, chronic osteomyelitis. Now we will discuss the diagnosis. Plain X-ray is not usually helpful because it will be positive only after 7 days, and it has low sensitivity. But still, we do plain X-ray to exclude another cause of pain in limb, for example, a stress fracture. We will do bone scan and MRI if we suspect osteomyelitis. And MRI is the basically investigation of choice because it has highest sensitivity and specificity. Bone scan will diagnose area of infection based on blood flow, and then we can also do CT scan to see little details, for example, small sequestra and erosions of cortical bones. And during management of osteomyelitis, sometimes we have to do bone biopsy when patient needs surgical debridement of and removal of sequestrum. We do surgery, and during that surgery we take a sample from bone because we want to um, know the causative organism. And if we do superficial sampling, it's not usually helpful because the normal skin flora, staph epidermidis, is normally present on skin, so it won't be that helpful. We have to do deep biopsy, which is bone biopsy, to check histology and gram staining. And there is this point that if patient needs surgery, if patient is on elective list, then we should stop antibiotics for at least 2 weeks prior to surgery, because we have to take sample during the surgery. And if patient is on antibiotics, culture will be negative, so we want to know the causative organism. That's why we should stop antibiotics 2 weeks before. Then blood culture can also reveal causative organism. So x-ray is to exclude stress fracture, bone scan and MRI to diagnose early stages of acute osteomyelitis, CT for detail, and bone biopsy to confirm organism. Blood culture is to confirm organisms. This is the diagnosis. We will talk about management of acute osteomyelitis in upcoming video.